Good evening. I'm Dr CHINMAY Mahatme, and I'm here today to share with you our findings regarding macular, microvascular, and structural changes in neuromyelitis optica spectrum disorders and myelin oligodendrocyte glycoprotein antibody disease. I have no financial disclosure or conflicts of interest to declare. So NMOSD and MOGAD are both demyelinating disorders of the central nervous system that have common clinical presentation. It can be tough to differentiate between the two in the OPD, and serology can be expensive, unavailable, and time-consuming. And these two conditions have very different prognostic implications for the patient and have a slightly different treatment approach on the long run. Another way to look at these demyelinating disorders is to study the vascular changes that occur in them. Hypoperfusion and predilection for watershed areas is already well established in multiple sclerosis. In NMOSD as well, vascular mechanisms are hypothesized to play a very important role, especially considering the fact that aquaporin 4 receptors, which are the main target in this disease, are expressed in the perivascular foot processes of the astrocytes. However, the chronology of these vascular events is not clear, whether these are causative or secondary to the neurodegeneration. So where can we study these vascular changes? In the retina, of course, because it's the most accessible vasculature of the central nervous system. And how? With the advent of optical coherence tomography angiography, we can study these vascular changes non-invasively, conveniently, and in great detail. So we wanted to study and describe the macular, microvascular, and structural changes in NMOSD and MOGAD using OCTA. And we wanted to evaluate the role of OCTA in the clinical approach towards the evaluation of these disorders. So this was a cross-sectional observational study at a tertiary eye care center in southern India, and the diagnosis of NMOSD or MOGAD was based on serological testing. We had 8 patients of NMOSD, 17 MOGAD patients, and 10 healthy controls. We used the Zeiss Cirrus 6000 Angioplex OCTA system for collecting the OCTA images, and we studied macular vascular density to represent the microvascular changes and the ganglion cell inner plexiform layer thickness to represent the structural changes. Our patients were around 37 to 40 years old in all the 3 groups. Most of the NMOSD patients were female. MOGAD had an equal distribution in terms of gender, and 70% of the controls were female. All of our NMOSD cases were unilateral. MOGAD had an equal distribution in terms of laterality, and this did not apply to the controls. There was an average 3 months duration between the onset of symptoms and the OCTA images acquired in these patients. And NMOSD obviously had a poorer visual acuity at presentation and a poorer visual recovery as well. So coming to the vascular changes observed, when we see the macular vascular density, this graph clearly shows that NMOSD and MOGAD patients, when compared with healthy controls, showed a reduction in macular vascular density even in the unaffected eye. In terms of structural changes, when we compare the GC-IPL thickness, compared to healthy controls, NMOSD and MOGAD patients show a reduction in GC-IPL thickness or GC-IPL thinning in the affected eye, but not so much in the unaffected eyes. When we carried out t-tests comparing NMOSD and MOGAD to healthy controls, the results that we just saw in the graphs were confirmed. When we compared NMOSD to MOGAD, however, we did not find any significant difference between the macular vascular density or the GC-IPL thickness in either the affected or unaffected eyes. So what do we learn from this? That reduction in macular vascular density is occurring even in the absence of GC-IPL thinning. And this correlates with the findings that have already been observed in multiple sclerosis by Montorio et al. In 2021, where they saw a progressive decrease in macular vascular density even in the absence of thinning. We need more insight into the mechanisms and chronology of these events. Lang et al. Have published a study recently on this very topic comparing NMOSD and MOGAD, and they did actually find a significant difference in GC-IPL and MVD, which could be used to differentiate between these two diseases. However, as far as our study is concerned, we conclude that OCTA cannot be reliably used to differentiate between these two diseases currently. We did note that in unilateral cases, if the other eye showed both GC-IPL thinning and macular vascular density changes, MOGAD might be more probable. We were not able to identify any subclinical contralateral involvement of the other eye yet. We have only studied the superficial vascular plexus in this study. This was a cross-sectional study design, so it did not allow us to study the chronology of these events that we have observed. And there was a lack of molecular pathophysiological rationale to explain the changes that we have observed. And we still need a larger sample size. So what is next? If we are able to describe the chronology and find the exact pathophysiology of these vascular events in these autoimmune demyelinating disorders, then it might provide very valuable insights into the diagnosis and management of these disorders. If OCTA can play a role in identifying contralateral subclinical involvement of the other eye or seronegative cases, it could be very valuable. These are my references. Thank you. Yes, ma'am. That is a good question. Actually, in our study group, we did not have, we excluded diabetics because of possibility of pre-existing microvascular changes in that, in those patients. But that is something definitely to be considered while evaluating the microvasculature. Yeah. In these patients that we have studied, ma'am, they did not have any other coexisting fundus pathologies. Yeah.
What?
Yes, ma'am.